Thank you. Uh, First of all, I would like to say thank you, Dr. Bansi Sabu sir, for giving me an opportunity to share the beautiful session on this DPP 4 symposia. And today we think that DPP 4 inhibitor drugs in the field of diabetology, as you are aware that every guideline says that early and intensive treatment is a key role of diabetes management in Indian diabetic phenotype. Sorry to interrupt you, my call is coming, that's why. But right now, today's era of diabetes management always says that intensive and early treatment of diabetes will improve the further mortality and morbidity. And for that, every guideline also suggests that the early initial combination therapy will work to reduce the further mortality and morbidity. And for today's our first talk, I would like to invite Dr. Kk Gangopadhyay from Kolkata. He is a renowned endocrinologist and has practiced extensively in India and abroad. After finishing his MD in medicine in India, the Gangopadhyay went to complete his MRCP from London and CGST in diabetes and endocrinology. He worked for 12 years in UK, of which the last 2 years were a consultant in diabetes in University Hospital from Birmingham. He has won many awards in UK for papers and presentation, including Owen Ward Award, Stephen Whitaker Prize, Nasi Prize, Society of Endocrinology Prize, and he has published over 40 papers, including international journals like British Medical Journal, Lancet, Diabetes Endocrinology, and Clinical Endocrinology and Clinical Medicine. He has been an investigator in multiple international trials. He has been the scientific secretary for Diabetes India and IDIACON, and he has been an overseas invited speaker to several countries, including Malaysia, Indonesia, Thailand, Qatar, and Nepal. I welcome you, sir. Over to you, sir.
Thank you very much, Chairperson, sir. Now, I would like to share my screen, if I may. Okay, I hope my slide is visible.
Yes, your slide is visible.
Okay, so thank you, Chairperson, sir, once again. Now, I put my timer on here so that moment 20 minutes are up, it will a loud bleep will come in. So I will stop then and there, whichever slide I am on. So that will make the job of the moderators easy. Now, Dr. Bansi Sabu has given a very high, a lot of words in this topic. So you can see the topic is in front of you. But actually, if you simplify it, the basic question is, Sir, आप कौन सा DPP4 inhibitor लिखते हो? Because this is one of the common questions asked in CMEs. Whenever I'm speaking on DPP4 inhibitors, one person will always ask, you have talked about DPP4, just tell me which one you are writing or which one you would write, just one. So I think it's a very good way to put this as a topic as well. So whenever this question is asked, I ask the question back. I said, who is the best opening batsman? Because currently a series is going on between India and Australia. So when I ask this, the automatic question is it a test match? Is it a 50-50 match? Is it a T20 match? Because if it's a test match, then Gavaskar has got a bigger circle. That means he's a better opening batsman than the other two. If it's a T20, then Sehwag. If it's a T50, then Tendulkar. So it depends on what match you're talking about. So I'm going to put all these 5 most commonly used DPP4 inhibitors, and I'm going to put circles on top of them. The bigger the circle, the better it is as compared to others. So there's no ambiguity, ladies and gentlemen, and this is purely, solely, and wholly my viewpoint only. You may differ from me, of course, but this is my viewpoint only based on the evidence which I'm going to cite. So DPP4 inhibition. So if you look at the DPP4 inhibition, So the sitagliptin has got a maximum DPP4 inhibition of about 97%. Vildagliptin achieved 95% on twice daily dosage. And I think the linagliptin is about 80%, but I think anything over 70% does the trick, and more than 80% definitely does the trick. So overall, and if you look at teneligliptin, it loses its DPP4 inhibition at close to 24 hours. It is the least amongst the lot. So if you look at DPP4 inhibition, this is wrong, not selectivity, it's inhibition. I would think teneligliptin has a smaller circle, and Sita Vilda has got the bigger circle, and Lina coming just after that. So now, newly diagnosed type 2 diabetes with marked hyperglycemia. I noted the chairperson sir talking about newly diagnosed type 2 diabetes. So I put forward this question to two audiences in a CME in Kolkata and in Hyderabad. So if a 52-year-old male executive, frequent traveler, meaning therefore that erratic lifestyle, erratic food habits, prone to hypoglycemia, therefore newly diagnosed diabetes, he does not have much in way of osmotic symptoms, only 1 kilogram of weight loss. So if anybody is having osmotic symptoms, catabolic state, insulin is the answer, full stop. But short of that, have you got any evidence with other agents? So HbA1c 10%, fasting to 50. So I offered these sort of choices, SU metformin, DPP4 metformin, and insulin. And I think the white bar is from Hyderabad and the yellow one is from Kolkata. Majority of the physicians and doctors present in the meeting opted for DPP4 metformin combination, which is becoming more commoner as the initial choice because there is much less hypoglycemia. And if you look at the evidence, albeit open label arms of patients who have got HbA1c 10% or above, with the DPP4 metformin combination, you can achieve a very sharp and marked drop, not sharp, marked drop in the HbA1c. So this looks too good to be true, but this is duplicated in almost all the DPP4 inhibitors. I don't have much data with teneligliptin, but these are the others which show marked drop in HbA1c. So if you look at newly diagnosed diabetes with marked hyperglycemia, apart from teneligliptin, all the gliptins share the same size bubble, meaning that they are all equal in reducing the DPP4, reducing the HbA1c. Ramadan, best test for an agent to prove that it does not cause much in way of hypoglycemia. Maximal studies is with vildagliptin. You can see the number of studies. The number of patients is higher with sitagliptin. And most of the cases, they're compared with sulfonylurea, showing that the hypoglycemia overall is less as compared to sulfonylurea in a Ramadan setting. So I think the maximal evidence, therefore, is with Sita and Vilda. I put a bigger circle for Vilda because of number of studies are more. So QTC, so we know that QTC prolongation leads to torsades pointes, and multiple drugs have been discontinued in the last decade due to this QTC effect. Now, mind you, they were not discontinued straight away. They have been used for quite a few months or years and killed several people before the authorities came to know that these drugs were the one which was causing the QTC prolongation. So it was only then that this guidance had come into place, mandating all the anti-diabetic agent producing companies that first you prove that it is QTC safe, then you say, then you launch, then you'll be able to market it. There's no point marketing it and then getting data that QTC is prolonged and you're killing people, then stopping the drug. First prove it. So in that proof, where patients are compared with moxifloxacin, where the agent is compared with moxifloxacin, which causes QTC prolongation. So if I go back, so there are three groups. One is the drug at the therapeutic dose, one is supratherapeutic dose, and one is moxifloxacin, and one is placebo. Why you need a supratherapeutic? If by mistake I take double the dose, if I've got CKD and the drug builds up, if I am prone to hypoglycemia, hypoglycemia itself causes QTC prolongation. If I'm more prone to hypoglycemia, the drug at the therapeutic level itself might cause QTC prolongation. So therefore, you need a supratherapeutic dose. There is no place for this argument, no, it does not cause at the usual therapeutic dose, it only causes at supratherapeutic. No, that is incorrect, because you need to prove its safety at supratherapeutic level as well for the reasons I have mentioned to you. So here, if you see in the teneligliptin arm, so moxifloxacin, the outer confidence interval, if it crosses 10, it's unsafe. So in the teneligliptin 160, all of it crossed 10, and in the 40 milligram, actually in the females, it did cross 10. So therefore, they will find it difficult in the USA to counter this, because when you're planning for a CVOT, they will also ask for this. But all the other DPP-4 inhibitors have had studies with the QTC at anywhere between 5 to 10, 20 times the dose. In case of linagliptin, it was 100 milligram, that is 20 times the dose, and still it did not cause any QTC prolongation. However, I put a bigger circle for linagliptin, because with the SITA and VILDA, the data is not that crystal clear. There were 1 or 2 areas where there was slight QTC prolongation after a certain interval, but with linagliptin, it seems to be a clean slate. So overall, all the DPP-4 inhibitors, barring teneligliptin, seems not to cause the QTC interval. With the CVOT data, we are all used to seeing this, and I'm not going to bore you with this. I've just included omarigliptin. This is MI, this is stroke, this is MI and stroke, and this is CV death. So you see, all of them are quite close to the midline. And the 4 main ones, if you look, the TCOS and the Carmelina on the right, and Sevatimi and Examine on the left. Now, if you look, they are all in the midline. So overall, DPP-4 inhibitors are CV neutral. As compared to Carmelina and TCOS, I think the TCOS had 100% patients with CVD, whereas Carmelina, in this case, linagliptin, 57% with CVD, and you have got higher patients, high number of patients with eGFR less than 60. However, heart failure at baseline, the number of patients were more, and the total number of patients was more with the TCOS, and TCOS had patients from India, whereas Carmelina did not. This was the basic difference. So if I put DPP-4 inhibitors and sitagliptin and CVOT, I think SITA and LINA have the same size bubble because they show neutrality. Heart failure, now if you compare all of them together, if you make a meta-analysis and a forest plot, the Sevatimi is the outlier, but all of them are in the center. Otherwise, even if you take out omarigliptin, it stays in the center. So as I said, saxagliptin, a 27% increase in heart failure. But if you look at the others, TCOS, it's right in the center, and Carmelina is actually favoring linagliptin, but numerically only, statistically not significant, meaning therefore that hospitalization to heart failure is not increased with sitagliptin and linagliptin. We don't have a CV outcome data with vildagliptin to say the same, and with saxagliptin there is increase in heart failure. And this is the data with the linagliptin, and the upper one shows hospitalization in heart failures with no history of heart failure. The lines are almost kissing each other, and hospitalization in heart failure with history of heart failure at baseline, actually the lines are almost the same, in fact, numerically favoring linagliptin. So assuring us of their safety. So I think I've put equal size bubbles for LINA and SITA in DPP-4 inhibitors and hospitalization due to heart failure. Now, inpatient use of DPP-4, I have been using DPP-4 in inpatient. My first choice always remains basal bolus insulin, but there are patients where there is just mild hyperglycemia, where I can manage with a DPP-4 and basal only, and I've done so successfully, but there is data to support it. So the 2 DPP-4 molecules which have got inpatient data is sitagliptin, linagliptin, the majority studies, and there is a smaller evidence with saxagliptin. Now, this is the data with sitagliptin, where you have 90 patients admitted to medicine and surgery, randomized to sitagliptin plus basal and basal bolus, showing that the sitagliptin was safe, less hypoglycemia, and less amount of insulin needed. With linagliptin, now in the last year, we have got data coming up. This is the LINA search study, which is a real world data. And this is a good study, in my opinion, because they used patients who were on linagliptin and basal insulin and compared it with basal bolus. Of course, the patients who were on linagliptin plus a basal insulin were allowed to have supplemental rapid-acting insulin if the blood sugars went up. So it's not just they were giving lina and basal only and no other insulin was added. That isn't the case. But basal bolus mandated that they will be on a basal insulin and 2 or 3 times of basal. The good thing about this study is that they were propensity matched for multiple factors, including duration of diabetes, age, sex, smoking, alcohol, presence of stroke, heart failure, everything else. So that's why I think this makes this study quite good. And if you look at it, patients after post-propensity matching linagliptin and basal bolus, percentage of patients who had hyperglycemia more than 200 was statistically not any different. Total insulin dose was actually much less with the linagliptin, so about 10 units less with the linagliptin basal dose. And importantly, the number of hypoglycemic events was less, and that was statistically very significant. You can look 21 events here and 12 events here, and that included patients with blood sugars less than 54 and less than 54 was not statistically significant. My apologies, less than 70 was statistically significant. So you can achieve equivalent glycemic control with less hypoglycemia, less number of breaks, less number of insulin requirements. And this was the real world data. And this is a randomized clinical trial using linagliptin compared to basal bolus. Here, it showed that patients who had blood sugars more than 200, for them, basal bolus seemed to do better than linagliptin. There was slightly more higher blood sugar overall. But if it is less than 200, then I think there is no difference. Importantly, the hypoglycemia rate was much lower, as you can see here, with 2 cases as compared to 14 with the basal bolus. So all in all, we have got previously, if I had wanted to show this slide in the beginning of 2019, I would have had to give a much bigger circle to sitagliptin and smaller circle to linagliptin. But in the last 1 year, we have had more data coming up with linagliptin. So I think because the data is more recent and there is both real world and RCT evidence with propensity matching, I've given a slightly bigger circle for linagliptin and DPP4 inhibitors as in patients. You've got very small data with saxagliptin, almost no data with teneligliptin. As far as the CKD is concerned, in the CVOT data, Carmelina has got most of the patients with CKD 45 to 60. And you can see here, with almost all of them, the CVOT, the CV neutrality is further proven even in patients who have got advanced CKD. In the Carmelina, there was a clear time to secondary kidney outcome data given to us as well, and that showed that the hazard ratio was 1.04. So the secondary kidney outcome here, you can read yourself, is the first sustained end-stage renal disease. So many of us thought that there might be benefit, but actually there wasn't. So just reducing albuminuria, which all the DPP4 inhibitors doesn't mean that it is going to improve or arrest the progression of EGFR. It does not, but at least it does not worsen it. So it's almost staying in the center. So I have put a bigger circle for linagliptin, although sitagliptin has got a lot of data with hemodialysis patients as well. The only reason why a bigger circle is because you don't have to make dose adjustments with linagliptin, whereas you have to make it for the others except teneligliptin. So for liver dysfunction, if I give you a simple case, which you and me saying day in, day out, fatty liver, what are the options we have? And we know that non-alcoholic fatty liver disease has a very high prevalence in our patients with diabetes. There is maximal data with sitagliptin, with human data with sitagliptin in non-alcoholic fatty liver disease, hepatitis B and hepatitis C. However, what is lacking is histological proof, which we don't have with any of the DPP4 inhibitors to that extent as we would want to say that it causes any benefit. but we have got more data with sitagliptin in patients showing reduction of the liver enzymes. The other DPP4 inhibitors also have got some data with non-alcoholic fatty liver disease, but I think here is important to mention that almost all of them can be used in patients with impaired liver function, barring severe, that is stage C child score chronic liver disease, where insulin is the answer. And of course, vildagliptin should not be used in patients with hepatic impairment. So I think here I would give a slightly bigger circle to sitagliptin because it has got a lot of data. So coming to the last bit, the cost, I think Tenali takes the cake here. Ours is a poor country. We have to think about the cost as well. Although in my opinion, my richest patient asks for the cheapest drugs more than the poorest patients asking for it. But still, cost is an issue in our country and we have to honor that. And in that respect, I think teneligliptin has got the biggest circle, followed by vildagliptin. My last slide, ladies and gentlemen, is therefore that you have to tailor your choice depending on the patient in front of you. Just asking which DPP4 won't get an answer out of me. Tell me the situation, you will get the answer out of me, and that is what it should be. So Chairperson, sir, I've got exactly 1 minute, 40 seconds left, and I'm stopping now. Thank you very much.